Hello? Okay, I will ask them to let you. Vinay, can you let Dr. Chopra, he's in the waiting room, can you let him inside? Vinay, can you hear me?
Yes, yes, sir. Yes, sir. I
Yeah,
had joined.
please let.
Yes, sir.
Abraham, you can start.
Good evening, everybody. It's a privilege for me to attend these academic sessions. And this has been Dr. Hari's brainchild, and we have been doing this heart failure masterclass. This is for the newcomers. Most of the people are not newcomers, but this is meant for postgraduates where there will be one student panel discussing, another student panel presenting. And today is unique because we will hear Dr. Rajesh having the OSCE and the exam, especially DNB exams. The biggest challenge is in the OSCE. People do pass in the practical, but OSCE is the biggest challenge. So I welcome everybody and I congratulate Hari and thank Hari for this a great venture. And along with Hari, I think Dr. Arun, Dr. Sajan, and Madhubal sir all actively participate in this. And with that, I hand over to Hari, and it is very nice to see the teachers, and the teachers are getting young and we are getting old. That's what is happening. But still, I think it's because you keep up the academics. So with that, I hand it over to Hari for starting this program. Thank you very much.
Thank you, Abraham, and welcome to the first session of this year's Heart Failure Virtual Masterclass. So we have changed the format a little bit. We will start with the session with a talk, not entirely related to clinical examination and all, something related to cardiology, which will benefit the residents. And then we'll have a short case discussion rather than going for the long case. And then when we have an OSCE session every month. So that is the plan. So this year, this is the first program. We have the session on AI by Dr. D. Prabhakar. I'm sure it will be very interesting. And then we followed by the short case presentation by Dr. Pramod and team from Sri Chitra. And the panel of students will be from Medical College, Calicut. And the pattern is one institute presents and the other students from the other institute discusses. Next year it will reverse. And that is the pattern which is followed. And then we will have the OSCE session by Dr. Rajesh, head of the department from Calicut Medical College. So with that, I invite Dr. D. Prabhakar to initiate the session on AI. He said he will be giving a practical tutorial rather than a talk on how to use AI. I think. I think he's the best person who is very, what is it, net savvy, and he handles our Twitter handle and he handles our all webinars and all other online programs. Over to Dr. Prabhakar.
So thank you so much, Dr. Hari, Dr. Abraham. I think it is wonderful to be here in this masterclass. And most of these masterclasses will start becoming redundant if you seriously keep following what I try to tell you. So let me start my talk by saying hello to my two very, very good teachers and examiners, Dr. Balachandar and Dr. Tarakan. And I reminded Tarakan of something that happened 30 years ago. I'm still surprised we both remember the same occasion. So what was my talk? My talk was on how cardiology residents can use AI in academics. So what you do first, you go to Google. That's what we normally do. You go to Google and search how cardiology residents can use AI in academics, which is what I did. But there is a small difference in what I did. I use the Google with the AI. So when I use the Google with the AI, it gives me a format of what is there, which is actually true. You can do a literature synthesis and research. You can do medical statistics and data analysis. You can also do clinical skill augmentation, like interpretation of ECG, echo imaging, which I will not talk. Probably if you have time, we'll talk some other time. You can improve your personal productivity and exam preparation. And you can also try something very simple. So when you want to do, like for instance, what I did, I asked a very simple question today and asked it to create a diagnostic quiz on ECGs. So when I asked it to create a diagnostic quiz on ECGs, it came up with this particular question set. It gives you you ask it for a multiple choice question, it will give it takes about 2 minutes for it to generate. So for an examiner, whoever is sitting here, life becomes very, very easy. So next you ask for the next question, it goes for them. You want a hint, it gives you a hint. It gives you everything. It will give you the key in the end. So what I will do is I will show you how you can utilize all this. Now, one of the go-to things that all cardiology PGs and everybody has been going is a free website, which is the Medscape. We go to Medscape, and in Medscape, you will notice that there is an artificial intelligence component. If you have not utilized it, please use it. For instance, I just typed, give me a summary of the latest cholesterol guideline, and it gave me the important salient points. It gives me all the different categories, the numbers, and then it also gives you the references, which you can go and cross-check. So this is a very simple method. This is just like Google, a little more advanced with references. This, I'm sure all of you will easily understand. Now, I will take you to the next level and tell you as a postgraduate, what is going to be more useful. As a postgraduate, what do? You go for a journal club. You go to this particular thing called Notebook. Notebook, if you go to the Notebook, it gives you an option to add sources. And it will give you all these outputs. It can give you a slide deck. It can give you a single page infographic. It can create a quiz based on that. It can give you flashcards. It can give you a video overview. It can give you a data table. Whatever you want, you ask for the output. Now, it takes time to generate all these things. So I will show you what I have already done. So I gave a talk about 3 weeks ago at the Lipidization of India National Conference, and my topic was HDL cholesterol. So is it really there, or is it a myth, or is it not there in primary prevention? So what I did, I prepared my talk, gave all the details inside. All my references are loaded here. So what I did the add sources. Like this, you get a view, you can drop the files, or you can search in it also. But I dropped the files which I thought was relevant, gave everything, and finally got details. So once I got my presentation, what I did finally, I got the entire presentation has HDL redefined and put it as a PDF. So finally, I asked it to make one infographic of the entire talk. Now, this is what it gave me when I asked for it. This is a summary of a 20-minute PowerPoint presentation. And I was shocked because it comes up with such a beautiful image. It says between 80 and 2005, how was HDL, 2010 to 15, 15 to 25. Now we have moved from quantity to function. What are going to be the priorities in management of cholesterol, the U-shaped curve, the trials, the genetic verdict, target, marker, everything, whatever I had in my about 20, 30 slides came up in one infographic with such a beautiful picture. Okay, I'll tell you how beautiful it was. Nathan Wong, who is the National Lipidization Chairman, was there. He asked me, Prabhakar, please share me your slides. So it comes up with such beautiful slides. So this is one way of utilizing Notebook. So how can you utilize it? All you have to do, if you have a journal club, just put that particular article and ask it to go and give you a slide deck. It will give you a slide deck. It will give you a PowerPoint presentation ready-made. It can also give you an infographic. And in this text here, below what you see, you can write down and say, give me a 1,000-word summary. It will give you a 1,000-word summary. You want 2-3 articles combined, it will combine the 3 articles and give you a summary. So whatever you ask, now the advantage of Notebook is you can restrict it to only the articles that you have given. That is the importance of notebook. Now, once you come outside this domain, everybody keeps talking about ChatGPT. Now, what does ChatGPT do? It's a little more different. So you can open a window, and what I did was I asked it for something. Compare calcium channel blockers. So when I asked it to compare calcium channel blockers and wrote a paper on it,
who can come to
Dr. Pramod, I think should be muted. Okay. So I asked it to do what I want, and I told it to give a comparison. I gave the data of my comparative study on 3 calcium channel blockers and asked it to come up with a table comparison. It gives me a comparison with 24-hour, daytime, ambulatory, everything. It gives you the mean, the standard deviation, and the p-value of the reaction. So the whole thing comes up in this. So at the end of it, I also asked it to give me a paper. I said, you write a paper with the references. So it writes a paper with references. I said Vancouver style. It gives me Vancouver style and comes up with this. But there is a big problem in the whole thing. What will happen is when it generates it in an AI model, which any good reviewer will be able to pick it up because they put it through an AI screening and they will pick it up. So you have to be careful about that. This is one way of doing it, where what I have done is I've given a data and told it what to do. Now, this is if you are going to be very conservative, you can do this. Now, if you're not conservative, this is something very different I did. I had a set of data of patients, about 76 patients, who had ambulatory blood pressure, home blood pressure, and office blood pressure. Home blood pressure for 1 week, 3 readings in the morning, 3 readings in the evening, complete set of data. And I told it to do what is called as an unsupervised exploratory analysis. So I didn't tell it what to do. It came up, it did a pre-processing, looked at the data, analyzed it, and divided it into 3 major components, and then came up into 3 clusters based on home blood pressure monitoring. Now, I didn't tell it what to do. It came up with 3 clusters and said the 0 is a stable one, 1 is an intermediate, and 2 is the one that is going to be problematic, high-risk problem based on home BP. It correlated this data against the ambulatory BP and said this classically represents the 3. So I asked what is the AUROC, which is the area under the receiver operating curve. It gave an AUROC of 0.83. So I said, if it is going to be 0.83, there must be some pointers towards what to be done. What about the clinical correlates? So it went ahead and searched the clinical correlates that are not part of the original exam and found out age and office systolic blood pressure were the clinical correlates. And I asked it to check it again. The AUROC came as 0.83 in that. So what I did, I had a remaining 500 patients data set on this, of home blood pressure monitoring. I asked it to validate it with that. Once I validated in that, it came an AUROC of 0.80. And I was not satisfied. I gave a third set of data from the net, which is all available for all of you to know. You search the net, you will get huge amounts of free data. I got an ambulatory BP data of 250 patients, applied the same formula to that. Once I applied it, the AUROC came up as 0.81. So I have done a very small number of patients, validated externally against home BP and ambulatory BP. And the net result, you have 3 clusters, identification of clusters by 2 simple clinical parameters, and you know that you have come up with a wonderful paper. Now you ask it to write the paper, it writes it, but you have to humanize it and change it later. So this is how you can do experiment with data. You have large volumes of data. If you supervise it and tell it, it will only come up with what you want. If you unsupervise it and let it do what you want, this is the biggest advantage. The large volume of data can be handled by this. Now you can also do one more thing. Like for instance, this is what happened. I gave a paper, submitted a paper in Journal of Cardiac Failure. Let's say Journal of Cardiac Failure, our paper is actually accepted. And the Journal of Cardiac Failure, I gave our heart failure registry from Tamil Nadu. And the reviewer had some comments. So I put both together and asked it to comment on what the commentator had, the reviewer had said. It gives you point by point where I have gone wrong and what should be corrected. I corrected it, wrote a reply, and just once the whole paper got accepted. So this is simple. Now, what I have done is I have elaborated the model a little more. This clinical model, what I've done, I've elaborated a little more. So what I do, I write a paper, send it to finish the paper, put it in ChatGPT, and ask it to review like a JCF reviewer. So it will review like a reviewer and give you the comments before the reviewer gives you. Correct the paper once, twice, thrice, satisfy ChatGPT. And if you want to be a lot more specific and a perfectionist like me, what I do is the perfected paper, I put it in a second AI model called the DeepSeek. ChatGPT is going to be more or less easy, but it's going to be paid. But DeepSeek is free. It's a Chinese model. It is free. So I put the paper in DeepSeek. It comes up with a different perspective and different ideas. If you pass these two, 100% your paper gets accepted. I also ask another very important question, which is the journal most likely to accept it? That also it gives you. And it will give you the chances of acceptance in each one. Now, you can also ask it specific questions. Like, for instance, my paper on 3 calcium channel blockers comparison, I wanted to know the data on what is the data that is available already on these comparisons. Very little data. It came up with a model like this. I told it to give it as a tabular column. So it gives me a tabular column with the 3 drugs that I wanted to compare. Office BP, 24-hour, home BP, everything. But I was not happy. I thought this is not going to look good. I said, you give it by studies. So I gave it a next prompt and said, no, you go by studies and give me another table. So it comes up with another table and gives me, based on the studies, what is the comparative data. So you can tailor it to whatever you want and do however you want to do. So there is no limit to the number of possibilities that can be done with AI. You can be a reviewer, you can be a writer, but at the end of it, you please check whatever you're doing. Don't blindly accept what ChatGPT says. All these AI models have about 20-25% chance of getting lies. If it doesn't know something, it'll straight away tell you some other answer. It'll cover up something and give you an answer. Be careful about it. The last point about AI, which you can use, very, very innovative, is going to be Claude. This is my last point I want to tell you. Claude is something where you can actually develop apps. It's going to take a lot of time to demonstrate Claude, but I'll just tell you, if you are brave, go to Claude, just ask it to do a clinical model on how to assess risk at coronary artery disease, how to do the gray score. You can develop your own app. You want to do anything on Claude, it is very, very simple. It will give you the code. It will give you an app. You don't have to know anything about it. I think in 15 minutes, I can only give you this much. I don't want to give you more than this. If there is time for questions, possibly I'll take a few questions here and there. Thank you, sir.
Thank you, Prabhakar, for that wonderful thing. And I think you should tell what all the softwares you use. Basically, I think many of us may not know. You said Notebook, you said Claude, you said. So, can you tell us for a beginner like many of the people sitting here, how do you start using the AI softwares?
Sir,
You need to go and spend time with Prabhakar.
So, Chopra,
Welcome,
sir,
Chopra, sir, welcome.
I'm so sorry I got late. There's problem of connection.
Sir, when you start, I think what you should do is download ChatGPT. And instead of using Google, start using ChatGPT and ask it specific questions. The most important thing is the question. So this is what they call as prompt. The question you answer, it will answer. It is dumb. So you have to ask questions specifically and tell it. So whenever I used to ask questions initially, I used to say, give it from a cardiologist perspective, from a physician's perspective. So after some time, it learned and told me, it'll start telling me, and I'll give you an answer based on cardiologist perspective. So it learns. That is the artificial intelligence. So just start using this. And any doubt, anything you want to ask, just straight away ask it. Don't hesitate. It will give you answers for everything. You have a paper, you don't understand, put it and ask it to summarize it. It will give you in a 1-paragraph summary how it goes. You want a podcast on this, you want an audio on this, you want a video on this, you ask it, it does it. So start using this. Claude, let us forget. Notebook is one big advantage, which is part of Google. Notebook is part of Google. You can download, all are downloadable. Notebook, the advantage is you can specifically restrict to one particular article that you want to see, which is what I think the postgraduates will be interested in. That's why I gave some importance to Notebook and told you what it can do. So you can make slides, you can make a presentation, and you can also do an infographic. Infographic is nothing but a single slide presentation of the whole thing. I think
I was
good enough, sir.
Sorry, I was using ChatGPT, and when it made some give me some slides, I asked it to give me graphs and tables. That it doesn't do.
So it will do, sir, provided you tell it to make it correctly. So you can't do it. You give the table and ask it to convert into a graph, it will give you. So in ChatGPT, if you want it specifically, like for instance, the one that I shared, it gave me the entire statistics in graphs. in my paper on that clustering that I showed you. It showed me the clusters, it showed me the graph. I hope I have it
But
with
many
me.
times it says, that this article is quoted. You go to that article and download the graph.
So those are all patented, sir. Patented things it doesn't let you do.
Okay.
That is correct. That is very, very important. That patented things it will not let you do. Like this clustering story that I told you. This is very interesting because it came up with the figures. I can show you the figures if it is there. I don't know whether it is going to be there. You can download the figures and it always works. And you can get perfect figures like how you want. And in fact, the last part when I did was when I started talking about this article, most of the journals, like including the Journal of Human Hypertension, keeps asking you about, you suggest reviewers. You ask it for the reviewers, it suggests the reviewers with the email ID also.
Oh,
Okay, another thing is yesterday we got an article submitted to Heart Failure Journal of India, 60% AI generated. So the system immediately detects it and tells that it is AI generated. So we don't accept anything AI generated. So that
he
is
has
another
an
issue.
answer for that.
I will give you the answer to that. All you need to do is whenever you use ChatGPT, this is you put /humanize, and then ask your question. It will be human. And at the end of it, you can run it through ChatGPT and ask it to find out what is the AI component. It will tell you what are the AI components, what all to change so that you don't get stuck.
/human/humanize.
Humanize or human, sir. So if your person who has submitted didn't know this.
And it is said that it will hallucinate and give some fake references which is actually doesn't exist. That is also there.
Those things that have to be checked, sir. Those things you have to counter check. You have to be very careful with the ChatGPT. Now, there is something in the ChatGPT which it's a little too much. You can go inside the settings and in the personalize and give it a particular command where it will reduce the chance of hallucination. And if it is doubtful, it will recheck, counter check and tell you it can't be done. I use it a lot. I put it in my personalized thing. So it is going to be there. Personalize, you can do it.
Actually, Prabhakar,
there is some question in the chat box. After giving incorrect answers to some questions, almost all AI models give repeatedly same answers. How to get appropriate answers in such situation?
Sir, all these ChatGPT ones or the AI models, you have to counter check the references. You have to counter check the answers. Like for instance, what happens in the same paper when I started doing an AI model, at 2 points, it gave me 2 AUROCs. Then I asked it, how was it possible? Then it gave me an answer saying, no, it all depends on how you ask the question. And it gives me an answer saying that this is what I did there and this is what I did here. If you want, I can give you this or that. So it's quite smart. So you can't cheat it that well. So, but it can give wrong answers. You have to be a little careful. And if you find out that it is giving a wrong answer, it will tell you, yeah, you're correct. You found out that I've made a mistake. It tells you that also. It's like talking to a human. In fact, you can talk to ChatGPT. You can actually talk to ChatGPT. And whatever you're writing, your writer, you can save it as a text or you can save it as an audio file also. So that you can keep listening to it when you go in the car. Everything is possible.
Prabhakar, I have one question.
Yes, sir.
Now, AI is of 2 types, generative AI and predictive AI. So you talked about the generative AI and how you can generate many things. What is its current role in predictive AI? That means given an ECG or given a HCM, what do you think would be the future of that?
Sir,
because
that
EF
is
prediction is now well documented.
So I didn't go into that. I specifically showed that part and told you I'm not talking about it. Because that is a much bigger topic, which is what I spoke of in the HFAI conference and showed how an ECG can be used to detect heart failure. It's a large model with an AUROC of nearly 0.90 in Africa. Just by ECG, it was able to find out who's going to have heart failure. And in a very middle, whether lower middle income country, this is going to be an absolutely wonderful tool. And it has been absolutely wonderful in pregnancy related heart disease. So it comes up as a very interesting tool in predicting things, but it is not foolproof. Your clinical plus this will really help. It is going to be there. And the entire model on hypertrophic cardiomyopathy also works very well. Cardiomyopathy, who are the patients who are going to benefit? And in fact, the atrial fibrillation ablation model, the best model was where AI went into the ECG and found out who's going to be responding.
And also ECG can tell you which person is likely to get atrial fibrillation in course of time. That also is there.
Very true. Very true. So that is what happened in that heart failure model, sir. that I think if I remember it was from Mayo or whatever. So
Yeah,
they
Mayo
did a
Clinic.
patient. They found out that 80% of the patients developed heart failure. 20% where it said had heart failure did not have heart failure. Now the prediction was EF less than 40%. Interestingly, on follow-up, those people developed heart failure.
Yeah.
So
Actually,
it seems to be either diagnosing or predicting. So those patients have to be under follow-up.
Mayo people came and gave a talk to us. Of course, most of it went above my head, but
Mayo Clinic has the largest, the Mayo Clinic criteria. Everything is now on there
everything.
for you to see.
Yeah.
They are doing the largest work on predictive AI.
Right.
In fact, ChatGPT has an interesting answer to me also. I kept on asking one question. The ChatGPT simply said, "I'm tired. I cannot keep on answering this."
Okay, so I think it is a very interesting topic. In the interest of time, we have to move forward. Thank you, Dr. Prabhakar. I think we'll have one more session on predictive AI with you sometime in the coming months. So thank you, Prabhakar, for that wonderful presentation. We'll move ahead. Next will be the short case presentation. We have two excellent faculty as the examiners, Dr. Jaganmohan Taragan was my HOD, and Dr. Balachandran, head of the department, was head of the department of JIPMER Pondicherry. So the presentation will be by Dr. Pramod from Sri Chitra, and the student panel will be, and Dr. Rajesh, I request you also to join as a faculty. And the student panel will be from Medical College Calicut. Over to the students and the examiners.
Yeah, I think we can get started with the short history, very, very brief history.
Correct.
Because actually, it will be an interpretation by the candidate or the presenter rather than from the patient's point of view, right? Because
Pramod, Pramod, you can make it the full screen.
On the history. Yeah, it could be very short, precise. Go ahead.
Am I audible, sir? Yeah, you're audible.
Yeah.
And please go ahead.
Good evening, respected teachers and residents. I will be presenting the showcase for this masterclass. 23-year-old gentleman from Kannur, employed in a hair dye manufacturing unit in Goa for the past 3 years, who presented to our hospital with complaints of exertional breathlessness for last 2 months, intermittent fever for 2 months, bilateral lower limb swelling with jaundice for last 2 weeks. History of presenting illness. Patient was previously asymptomatic for 2 months back when he started experiencing breathlessness, which has progressed over a period of 2 months from NYHA class 2 to 4, and currently requiring hospitalization. It was associated with multiple episodes of orthopnea and PND. Patient also noticed bilateral lower limb swelling for past 2 weeks, which is up to shin, and is associated with upper right quadrant abdominal discomfort and loss of appetite. Patient has also noticed yellowish discoloration of sclera for last 2 weeks. Other than this, there has been a history of intermittent undocumented fever for last 2 months, which is predominantly evening rise, and there has been no associated chills and rigor. He was initially evaluated elsewhere and diagnosed to have a heart disease and was referred to Sri Chitra for further evaluation. There has been no history of chest pain, palpitation, syncope, and fatigue. No history of hemoptysis, no cough, wheeze, or diurnal variation, no history suggestive of rheumatic fever, no history of tuberculosis, no history of any recurrent LRTI, cyanotic spells in childhood, and no history of small joint pains, photosensitivity, or alopecia. Coming to past history, no prior medical or surgical illness, no known comorbidities. Personal history, patient has been a regular alcoholic. He consumes whiskey with 15 drinks in a week for last 3 years, making his alcohol gram content of 200 grams per week. Coming to smoking, he smokes 3 cigarettes per day for last 3 months, making his pack year to 0.04. No history of high risk behavior. Occupational history, patient has been employed in a hair dye manufacturing unit for past 3 years, and he has been involved in a regular handling of following chemicals, which includes phenylene, diamine, and resorcinol, along with sodium sulfate and polypropylene glycol. As per patient, he has been using personal protective equipment effectively. Coming to family and social history, no, there is no similar illness in the family and no family history of sudden cardiac death. Prior treatment, Patient was evaluated initially elsewhere and was treated empirically for suspected leptospirosis with oral antibiotics. As there was no clinical improvement, he underwent further investigations and was told to have a heart disease. He was admitted there, treated with diuretics and oxygen support, and was referred to Sri Chitra for further evaluation. Summarizing my case, 23-year-old male with a progressive biventricular heart failure symptoms over a period of 2 months, which has progressed from NYHA 2 to 4 with orthopnea and PND with recent onset pedal edema and jaundice, along with intermittent undocumented fever during the same period.
Yeah. So what would be your interpretation, basically? What do you think will be the pathophysiology behind all these symptoms, which have been maybe subacute? It has not been an acute onset with a bad improvement. It has been a gradual but fairly rapid progression, isn't it? So you can just tell us what comes to your mind in the pathophysiology. You
So
did
to
say
begin
that
with
progressive biventricular failure, but yes.
To begin with, it was initially a left heart failure, sir, which has over a period of 2 months involved a right heart failure and which has manifested in terms of pedal edema and jaundice, sir.
You think it was started as a left heart failure, progressing to a biventricular failure? Or you think to
Sir,
start with itself, it was a biventricular failure?
Sir, his initial complaints were dyspnea, or dyspnea along with orthopnea and PND. Pedal edema and jaundice has been noticed in the last 2 weeks, sir.
Okay.
No,
I mean,
actually,
there are two things you have to probably give a little importance to. What is the intermittent fever? Do you think it has any importance? And second is
Sir,
working in a factory with some of these chemicals which could be cardiotoxic. Anything to do
regarding
with
the
these
fever,
two
sir,
histories?
it has never been documented, sir, fever. As per him, sir, as per the patient, he was feeling feverish in the evening. He didn't seek any medical attention till last 2 weeks, sir.
Some of these chemicals you are told, of course, we are not very familiar with it, except that ethylene glycol and all, which had come into news, because in Andhra Pradesh, a lot of children died with using of consuming cough syrup, which actually contains ethylene glycol, but not the product that you have mentioned here, I think. So, do you think this also can cause cardiac toxicity? And I don't know whether he can get exposed to it by his profession.
Sir, we have done the literature search for these two chemicals. These two chemicals has been mentioned in are called cardiotoxic, but the presentation is completely different. Initially, it will be a angioneurotic edema along with sudden onset breathlessness, leading to even patient have to be ventilated and even tracheostomized.
No, that's okay. No, what type of exposure of these chemicals that he must have been exposed to?
Yes, sir.
Well, is it through inhalation or is it through contamination with his
sir,
food or
these
or
chemicals can be cardiotoxic
or mucous membrane?
Sir, all the three routes are possible, sir. Contact dermatitis through mucous membrane and through ingestion. All the three routes are possible. But as per patient, he was using all the personal protective equipments while handling these chemicals.
All right. So do you think it's some acute event which has progressed, or you think it is a subacute event which has progressed to now class 4 and orthopnea, PNDs and all that?
Sir, as
not
per
an
history,
acute one,
doesn't
like
look
an
like
acute
an
MR,
acute
acute AR, or acute ruptured sinusoid salva.
Sir,
doesn't look
there
like
has been
that,
no
doesn't
history of palpitation or any other symptoms. Only his complaints were dyspnea, sir.
Yeah, it has been a
like
rapidly progressive,
probability of
gradual. It's a rapidly progressive thing. It didn't start as an acute episode. So, what comes to your mind,
Yes, sir.
etiology-wise?
So, what is if you say biventricular failure, it started with the LV, and you are now putting
Yes, sir.
the whole dye industry into peril by saying that the dye is responsible for the cardiotoxicity. Then, because I'm sure millions of people use dye every day, almost every day, and then it will create problem. So, what do you think has happened? The LV has got affected first, and then the RV, or both have got affected at the same time?
The student panel can
So the
also
symptom
join. Student panel from Calicut also can join the discussion.
Sir, the
Based on
symptomatology
history,
suggests
it
like
is
first the left ventricle was involved.
So what's the pathophysiology of
Is it
LV
some sort of
involvement first,
myocarditis?
followed by RV? And what is the pathophysiology of LV and RV almost simultaneously getting involved? What is the difference and what's the pathophysiology? How does RV get involved secondary to LV involvement? You can just tell us the
Sir,
hemodynamic or pathophysiological mechanism.
Yeah, correct.
in the
Anybody
first place, if both the ventricles were involved, sir,
Oh, you think it is a biventricular to start with? Suppose I say no, the history is fairly typical of acute left heart symptom followed by secondary right heart. So what could be the pathophysiology?
So
How
it
does
would,
acute
it would be a
left heart
gradual
failure
elevation of
result in
pulmonary.
acute right heart failure or biventricular failure? Mechanism only I'm asking. Simple.
Gradual elevations of pulmonary capillary wedge pressure leading
Yes.
to pulmonary arterial hypertension and leading to right heart failure.
Okay, so
its
pulmonary venous
symptoms suggest that
hypertension,
a
pulmonary
symptom
artery
initially-
hypertension, right ventricular dysfunction, right ventricular failure. Any other mechanisms?
sir, usually long-standing heart failure, long-standing left heart failure progress to
It's
right
not
heart
long
failure.
standing, isn't it? It's certainly
Yes, sir.
historically
Here
it's very
within
short.
the 2 months. Yes, sir. Within the 2 months, so definitely at the first place, some right ventricular involvement was also there, which has now decompensated and led to uh, edema and jaundice, sir.
Okay, forget
In
about
any
this.
acute situation, there can also be what is called a pericardial restraint. So, like acute MR, acute AR, it can
Yeah.
cause actually biventricular failure pretty quickly because of the pericardial restraint. The volumes are restricted, so the fillings is restricted, so the patient goes into almost a biventricular failure.
So
But
the
you don't
situation-
suspect a pericardial disease here, isn't it? Or do you suspect a pericardial, myopericardial, or a valvular disease? So that at least you can suspect. Or it's difficult to
Based
tell.
on history, it looks like
Difficult.
based on history, it is purely a myocardial disease because the patient doesn't have a history of chest pain suggesting
Yeah.
of involvement in the
Certainly,
pericardium.
a pericardial, he should have at least classical pericardial pain. So it doesn't look like a primary pericardial. So it has to be either myocardial or
Primarily myocardial.
So what is the situation in which a similar thing can occur? Forget about the die and the thing. What is the situation in which a similar thing can occur? First, there is a left heart failure and then a right heart failure. Something you have created in the lab. What is it? You have created something. Just now, Dr. Tarakan told about. What have you produced in acute MR?
Sir, some ruptured sinus of Valsalva, sir. Sinus of Valsalva, which has now ruptured and led into.
Yeah, could be. Or due to balloon mitral valvuloplasty also. When you produce an acute
BMB leading
MR
to,
due to
yes, sir.
BMB, then what happens is that the patient doesn't go into the pulmonary edema. Many patients will go into pulmonary edema, but some patients will not. And then as time progresses, they go into biventricular failure and they'll come back to you with pedal edema, jaundice, etc. So this sort of situation can occur following an acute MR, which Dr. Tarakan has already mentioned. Okay. So you have
Still
had
like to consider infective. Sir, I would still like to consider infective endocarditis, though there is no high grade fever, but still there is still a long standing history of fever with the predominant right heart involvement initially leading to left heart leading to right heart. Still would like to consider left heart endocarditis in the differentials.
Okay. So it could be myocarditis, it could be endocarditis.
Yes.
Yes, sir.
All right.
what type of endocarditis are you thinking of? Primary right-sided endocarditis in a man who is otherwise healthy, but then exposed to alcohol, cigarette, and we do not know whether he has any other drug addictions and all this. Of course, probably you said no. Obviously, here it is primarily left heart. So I don't think a drug addiction related right-sided endocarditis. It's very rare to have left-sided endocarditis, though it's possible. Yeah. So we are focusing on myocardial problem primarily, isn't it?
Yes.
And whether it's dominant left or biventricular or left followed by right, we'll have to say. Shall we go to the
examination?
Yeah, physical findings. I think that might give you some clues.
Okay, sir. Coming to general physical examination, patient was conscious, cooperative, and oriented. His weight was 43.2 kg and height of 152 centimeter, making his BMI of 18.6 kg per meter square. Pulse was 66 per minute, regular, low volume, no radial, radiofemoral delay. All peripheral pulses were palpable. Blood pressure in right arm 90 by 76, left arm 88 by 76 mmHg, and left leg 100 by 78. Respiratory rate was 28 per minute. Patient temperature was 99.8 degree Fahrenheit. Room air saturation was 93%. Scleral icterus was present and sublingual mucus was icteric, and bilateral pitting pedal edema up to shins was present. JVP was elevated up to the nearing up to angle of jaw in sitting position with prominent A wave, normal B wave with sharp descents. There was no pallor, cyanosis, clubbing, or lymphadenopathy. On examination on general physical, patient had brachydactyly with a marked shortening of the third metacarpal, and there was no evidence of contact dermatitis due to chemicals over his hands, and no signs of hepatic encephalopathy. This was his hands picture, and his we can see the this third finger is short compared to the fourth one.
Okay, okay. Anyway, there is no hypoplastic, thumb and all those things are not there. Basically, all the metacarpals are small.
Yes, sir.
Okay. It's a very good observation. I do not know whether it can relate to any cardiac problem. I do not know. Have you checked brachydactyly and any cardiac problem, congenital or otherwise? Calicut people?
Sir, we have checked, but no such relation with any myocardial disease has been observed.
No, not myocardial.
Okay, so,
It could be
it's a good
congenital
observation. Let's go ahead and see.
Could be autosomal recessive, no? Like Ellis
I think those scars are probably due to intravenous medications and all.
Yes, sir. These
Okay,
were cannula marks.
Yeah, okay.
And no clubbing.
No clubbing, no splinter hemorrhages, nothing. Okay.
No clubbing. Yeah. Coming to CVS examination, sir, inspection and palpation has been discussed together. Chest was bilaterally symmetrical and tracheocentral. No scar or sinuses. Overlying skin appears normal. Apex beat felt in 6th intercostal space, 2 cm lateral to mid-clavicular line, and sustained in character. There is no left parasternal heave, no thrill or palpable heart sound, no carotid thrill. Cardiac auscultation. First heart sound was normal. S2 was normally split and P2 is normal. Left ventricular S3 gallop was present. No clicks or additional heart sounds heard. And a soft graded 2/6 penisystolic murmur at the apex with no radiation to axilla or base of the heart. No mid-diastolic murmur heard at the apex. And with deep inspiration and head grip, there was no change in the murmur intensity. Other system examination, respiratory system, bilateral air entry was equal and bilateral basal crepitations were heard. Coming to abdomen, hepatomegaly was present. Both hepatosplenomegaly, hepatomegaly was non-tender and liver span was 17 centimeter, non-pulsatile liver, and CNS examination was normal, within normal limits.
Okay, so tell us what's your interpretation of all the physical findings. You have got a lot of findings, so tell us.
Start with JVP.
Yeah. JVP.
Yeah, here's right heart failure. Obviously, that is your physical findings first because jugular venous is intracranial and it's not related to a primary TR or something. It's a mean JVP which is elevated with the usual pattern of a heart failure with rapid vice descent. Okay, so he has right heart failure. Now tell us why he has right heart failure. The presence of cardiac findings which are related to the left heart.
Pulse pressure was low, sir. So
yeah,
pulse pressure was low, sir. 88 by 72.
Yeah. Okay, so pulse volume is low. But what about the pulse itself? Pulse itself is very low, isn't it? 60.
Yes, sir. Low volume pulse.
Are you surprised? No, forget the low volume. That's expected. But why the pulse is low? Do you think he's in sinus rhythm or do you think he's not in sinus rhythm?
Something.
Sir, pulse was regular, sir. Sinus
Regular is not necessarily sinus. It could be just a junctional rhythm. So how do you make sure that he's in sinus rhythm? Yeah.
Yeah, JVP. That's why I
Ventricular rhythm can be idioventricular rhythm also, isn't it? Or heart block with regular ventricular rhythm. So jugular venous pressure and pulse volumes. Change in pulse volume basically means there is no AV synchrony, right? Volume is regular, then there is AV synchrony, or it's a regular with atrial fibrillation with a regular ventricular rate. Okay. Yeah. Then look at the JVP. Look for the A waves. If they are regular, exceeding the carotid, then you know it is probably sinus rhythm or a low atrial rhythm. I mean, that you cannot separate out. If it's a junctional rhythm, you are going to get regular or irregular Canon waves. So that's why, yeah, because heart rate 60 is a little odd for a patient who is in severe biventricular
heart failure.
Do you think it can be due to the therapy of heart failure that his heart rate is low?
Yes, sir.
Which therapy is likely to have been given, which could reduce the heart rate?
Beta blockers.
Beta blockers.
With wet lungs, beta blockers very unlikely, to be given. But people still feel, heart rate below 70, and if the patient cannot tolerate beta blocker, then some other drug is given. What is it?
Ivabradine, sir.
I can't hear you.
Ivabradine or digoxin, sir.
Okay,
Ivabradine, yes.
Ivabradine, certainly, yeah. Ivabradine is basically neutral for arrhythmias. It's probably neutral for heart failure. Digoxin, of course.
And digoxin also, sir.
Even it can be digoxin. Okay, go ahead. So there is cardiomegaly, which is certainly left ventricular type, and the only odd findings are that he does not have pulmonary hypertension clinically, and there isn't any evidence of tricuspid regurgitation to suggest RV dysfunction. Right? Isn't it? Generally, RV dysfunction should give you some evidence of tricuspid regurgitation. Is it just ventricular interventricular dependence? What is this ventricular interdependence? I'm sorry. Just 2 lines on ventricular interdependence. Then we can go ahead to the next.
Then respiratory variation of the JVP will not be there, sir. If we are suspecting ventricular interdependence, like temporal.
Yeah, that's another way of looking at it. Did you look at the respiratory changes in the JVP? Was a small sign positive? Or it was already at the jugular angle of the jaw you couldn't make out?
Sir, it was approaching the angle of jaw, but waves can be seen, and the respirophasic variation was there, sir.
I mean, normal respiratory collapse,
yes, with inspiratory decline.
Maybe.
Just one offhand question. What is atrial Bernheim effect? We know about ventricular Bernheim, but what is atrial Bernheim effect? Do you know what it is? No. So in mitral regurgitation, and then when the LA expands, the intra-atrial septum will move towards the right atrium, and that can give rise to some sort of an A wave as a result of the
atrial interdependence also. Atrial interdependence also.
Atrial
especially very huge RA, very huge LA, which is acutely dilated, or subacutely, as in this case, just like ventricular. They have described it for the atrium also. No, the only problem is because you have said there is no right ventricular pulsation, there isn't a parasternal heave, there isn't any pulmonary hypertension. Obviously, the patient has to have pulmonary hypertension. What about the chest? Was the chest clear, or was it some basal rales?
Traps were there, sir. Traps were there.
Oh, basal rales were there. So obviously, pulmonary venous congestion. So obviously, some pulmonary artery hypertension has to be there, but not high enough to be appreciated clinically, right?
Yes, sir.
Shall we just go to the next? If we have no more. So we know it's a myocardial disease, isn't it?
Disease, yes.
Right.
Yes,
and because the murmur of mitral regurgitation is certainly functional mitral regurgitation. What is functional mitral regurgitation?
Due to left ventricular dilatation, there is annular dilatation leading to without.
So it can be
mitral
ventricular, left ventricular, or we can left atrial.
Yes, sir. Atrial functional MR.
But this obviously is likely to be
Ventricular
ventricular, yeah. Just
Ventricular.
cardiomegaly. The other one,
Ventricular
atrial type
functional
is
MR.
regularly either due to arrhythmia or diastolic dysfunction of the left ventricle. So where there's not much of
Yes, sir.
cardiomegaly. Okay, good. Lala, shall we go to the next?
Yeah, go to the
Yeah,
ECG.
good.
Yeah. ECG should show something.
Yes.
Because
Coming to
bradycardia.
ECG, sir, sinus rhythm with heart rate of 65 and PR interval is prolonged, sir, around 220 milliseconds. And QRS duration is around 90 milliseconds with excess of around more than minus 90, sir. And PR interval is PR interval prolongation is mainly caused by the increased P wave duration rather than PR segment, sir. And there is
Low voltage frontal plane.
biatrial enlargement with incomplete RBPB.
Yeah. Okay. So no, wait. Please let's
Go
have
back
the
to ECG.
ECG. Yeah.
Okay,
Please
sir.
interpretation of the electrocardiogram. I agree with you. Your heart rate is just around 70, not as low as 60. Okay. 8 to 70. All right. Good. Of course, the QRS axis is almost indeterminate or right upper quadrant.
Indeterminate.
But
Yes.
I would
Yes, sir. More than minus
they're
90
on the side of
between
left axis deviation
maybe.
because the KVL looks a little, QR pattern, right? So it can be extreme left
Yes.
axis, which is just more negative than minus 90, rather than extreme right axis. Okay, so it's low voltage, but is there a disparity between the QRS and the P voltages? The P voltages look well preserved.
Low voltages in limb leads.
There is low voltage in limb leads and
Standard leads also, it's all full, it's a normal standardization. So
A little less
test leads also, none of them has more than 10 millimeters. So
generalized low voltage.
anyway, okay.
Sir, also
So
I
what's
would
the
like to focus
interpretation?
on one more point, sir.
Clinically, it's a large left ventricle. So this favors maybe like a familial dilated cardiomyopathy or a patient on dilated cardiomyopathy with worsening, or you think it is something acute?
Sir,
Or
nothing to
subacute?
suggest acute. Looks like chronic myocardial disease.
This is myocarditis or
Yes, sir.
there's extensive myocardial damage which can give rise to low voltage, no?
Biatrial enlargement is there, sir, suggestive of chronic pathology.
Okay.
But there are no Q waves in V5, V6 signifying any left ventricular volume overload.
Okay.
Yeah, I think the ST things are also very non-specific. Really, I mean, the most striking is for that type of cardiomegaly, it's a low voltage pattern, but predominantly the QRS loss of QRS voltages than the P. Of course, we think of restrictive cardiomyopathies, but I don't think we are going to consider restrictive cardiomyopathy in this case at all with that cardiomyopathy. But right, the classical restrictive cardiomyopathies, the ventricles are not really large. It's the left rate, and that is how you get this point. No, it's got between the P and the QRS axis. But here, I think we should still continue to think it is myocardial problem, and low voltages may be due to inflammation or edema of the myocardium. Right? In dilated cardiomyopathy, usually, you get larger voltages because of the Brody's effect and all that. The large ventricular volume allows better conduction of the electrical activity from the posterior wall. Bala, what do you think about the ECG? Does it give us
no, there was a suspicion I also thought could be restrictive type of pattern, looking at the voltage, low voltage.
Calicut?
But then looking at the history, I think it is just a reflective of extensive myocardial damage or myocarditis, which can give rise to this sort of a picture. Although STT changes are not very prominent here. And axis, of course, is northwest. Its AVR is positive. It's gone into the right upper quadrant.
Yeah, it's a right upper quadrant, but AVL being
negative.
Just around, I mean, would be equivocal.
Equiphasic,
We would call it minus 90.
Okay,
but
fine.
it doesn't matter. I agree with you. It's plus some incomplete RBV. Yeah. There isn't a gross. I do not know if you said the PR interval is slightly prolonged. Maybe you are right, but we can't make out here. But I don't think it's a primary conduction system disease with a cardiomyopathy. I don't think so. I think it's a primary myocardial disease, and the electrocardiography is just.
Sir, actually, there
Anybody
is
else?
evidence of interatrial block also in this ECG. We can see that on a background of prolonged PR interval with most of the contribution from the
Right
P
atrium.
wave. In the lead 3, the last part of the P wave is negative, which signifies that there is a possibility of interatrial block also.
I'm sorry, I can't follow you.
This,
Sir, in this patient, the PR interval is prolonged and most of the contribution is from by the P wave, not by the PR segment, sir.
Yeah.
PR segment is short only. So
yeah, that's correct.
it
So
gives
it
a hint
is,
that
it is a left atrial enlargement. That's basically typical
Yes,
of left
sir.
atrial enlargement.
Really,
Right atrial,
Just,
you are only assuming.
left atrium is
For whatever
encroaching on the
reasons, I
PR
do not
segment.
know. Because the bifidity of the P wave, as well as the P to PR segment ratio, all those things favor left atrial. V1, of
Yes,
course,
sir.
is
Yes.
always difficult to tell, but it has already become positive in V2, which could suggest that
Both
there
Morris
is
and
a
macros
disease
are
also.
positive, sir.
Yeah.
Transition very quickly to V2 indicates it is more side right atrial rather than left atrial. It's a biatrial enlargement. I agree with you. I would agree with you. Okay, let's go to the X-ray.
Okay, sir.
Yeah.
X-ray shows cytosolitis levocardia with cardiomegaly with CTR of 65%, sir. With the right atrial enlargement and left ventricular type of excess. Cadenal angle is almost 90 degrees, so but by shadow in shadow is not clearly visible here, sir. But we can, with cadenal angle, we can say that left atrial enlargement is there, sir. And borders are very sharp. Either it is due to pericardial effusion or severe left ventricular systolic dysfunction. And the vascular pedicle is also enlarged, suggestive of dilated SVC and probably azagus vein also, sir. And
upper lobe veins.
Stage 2.
Yeah.
Stage 2 PBH is there, sir, with the involvement of upper lobe, and we can see curly lines also, and interfiscial edema is also there, sir. And there is no skeletal abnormality of the ribs or neck.
I don't think that transverse fissure is. It is probably even normally it will be visible because you are seeing it perpendicularly, so it will always be seen. So I don't think there is pleural effusion because interlobular thickening means there is pleural effusion. Here it's not. Both the angles look quite
CP angles,
okay.
both the CP angles are blood, sir.
Okay, maybe you have a point in that, but right looks clean. I agree with you that cardiac border, the silhouette is very sharp.
Very sharp.
Basically indicate there is very little movement. Pericardial effusion is the first,
Yes,
but
sir.
Certainly with severe LV dysfunction also, this could happen. And obviously there is pulmonary venous hypertension, but beyond that, I cannot say there is interstitial pulmonary edema or peribronchial puffing. All these things are not really seen.
Yes, right.
So do you think the right-sided failure is protecting the lungs from acute problems of pulmonary venous congestion?
Could be. There's right atrial enlargement.
For that, some pulmonary artery hypertension has to develop, sir.
I'm not so sure, but maybe the pulmonary artery is just pulmonary segment is full. No, we are not doubting pulmonary artery hypertension because severe pulmonary venous hypertension because of the symptoms.
Venous hypertension
certainly
is
yes,
there.
pulmonary artery hypertension, but it's not very severe. And I think the right heart failure is significant, which protects the left heart, because the right heart itself, the stroke output is low. That must be the reason
because of
why.
right ventricular dysfunction, you have less
right
input into the lungs. You do not get pulmonary arterial hypertension to produce that.
Yes, sir.
Even right ventricular dysfunction can produce.
Yeah, it can be secondary to pulmonary artery hypertension, which we are not so sure here because main pulmonary arteries, RPA, RPA and all are quite not all that prominent.
Correct.
Okay, I think that's Bala, what do you think? Shall we say it's a biventricular cardiomyopathy?
It's a generalized, we should describe this as a generalized cardiomegaly. There is right atrial enlargement and the borders are very sharp. There's no doubt about it. Pulmonary venous hypertension and possibly left atrium.
Pericardial effusion, but I think it was large atrial voltages,
Electric,
I don't
yes.
think that is going to be the primary cause.
Yes.
Yeah. And clinically also, you got a very good sustained effect, which is certainly means it's a dysfunctional left ventricle.
Left
and I don't
ventricle,
think
yes.
you have done a percussion to see if the cardiac effects and the outer
Dullness.
limit of dullness coincide or not. That's a way to diagnose pericardial
Pericardial
effusion if
effusion.
possible. Okay, let's go to the next. I think we are running short.
Sir, coming to echo, sir, left ventricular diameters was 79 by 71, suggestive of severely dilated left ventricle, with EF was 11% by AL method. Left atrium was 41, borderline enlargement, and global LV hypokinesia were there, sir. And RVSP was 20 plus right atrial mean. M mode across the IVC, sir. IVC is usually dilated, and hepatic vein is also dilated. Maximum diameter 27, and it is showing a respiratophasic variation with minimum diameter of 18, suggestive of around 33% decrease in the size, which
Okay.
corresponds to a mean
Yeah, I
right
agree with
atrial
you.
pressure of 10.
Please remember the limitations of this is sometimes, the IVC goes out of your sector, and hence you might get falsely narrowing and all that. I think, but you're right. I think IVC is dilated 2.7, isn't it? That is enough. And inspiratory collapse, people would say 50 less than 50% or and all that is okay. Good. Next. Yeah.
Coming to M mode across the mitral valve, sir. Both
Yeah,
the right atrium, both the left ventricle and right ventricle
Dilated.
are hugely dilated with marked septal thinning and posterior wall thinning. The E-point septal separation is more than 10 millimeters, suggestive of severe LV dysfunction. And there is premature closure of mitral valve, and there is a P bump on the AC shoulder of the mitral valve MO, suggestive of elevated left ventricular diastolic pressures.
And diastolic pressure.
I don't think there is premature closure, please. I don't think so. What you're showing is probably the B hump.
B hump
The AC is
only
very prolonged because of the B hump. You get my point, no? The peak A to the closure point is prolonged. There's no pre-close. I don't call it pre-closure. Pre-closure should close completely. It's open. It basically probably indicates that LVADP is also very prolonged, very elevated. Okay, it's obvious. Next, there is no pericardial effusion. Okay. Quick.
Flex view showing dilated left atrium with poor contractility of LV and dilated RV. Short view showing pulmonary artery is normal. And apical four chambers are both the atrium and both ventricles are hugely dilated.
No, and you can, of course, that's a very nice, the mechanism of MR, no? Isn't it? The closure point is well into the ventricle, not, because of displacement of the mitral leaflets by the pulmonary muscle displacement due to almost global LV. Okay, next.
Pericardial effusion is also there, sir, posterior to ventricle.
Minimal.
Small quite.
Mitral MR jet is seen, sir, around moderate MR, sir. Central jet probably due to leaflet non-coaptation. Moderate TR is also there.
Yeah, go ahead.
Strain was done, sir. Left LVGLS was -3% and EF was coming 15% by LVGLS.
Okay, good.
Then post-systolic
shortening
global
longitudinal
was done, which is yes. It was showing that segments are contracting, but they are out of phase. And post-systolic dispersion time was 103.9 millisecond, which is showing significant dysynchrony among all the LV segments, sir. Then we did the hand X-ray also, sir, bilateral PA and oblique view. We can see the middle phalanx of second, third, and fifth is markedly shortened compared to first, the great thumb and the ring finger, sir.
Okay. Anyway, all the metacarpals are intact. There isn't any absence of any of those. So, okay, go ahead. Next.
We went ahead with cardiac MRI for the patient, sir.
Yeah.
Sir, this is the four-chamber cine view showing hugely dilated right atrium and left ventricle with very thinned out septum, and all the LV myocardial is also very thin. And there were two non-enhancing lesion in the right ventricle RV apex signifying clot. short axis cine speed sequences were done, sir, showing both the left ventricle and right ventricle. Both the ventricles are dilated, and we can see a ring-like subepicardial enhancement encasing the full of the left ventricle, interventricular septum, and it is encasing the free wall of the right ventricle also. And T1 and T2 values were not much dilated, were not much increased, maybe suggesting a healed disease.
Sorry, I couldn't follow. What was the interpretation of this T1, T2 sequence?
Sir, they are not a mark. It is suggestive of not an active disease, sir.
T1 value will usually suggest a myocardial edema.
Myocardial.
Yeah.
Edema.
If the values would have been T1 value around 1300 or 1400, may suggest that some active disease is still going on, sir.
Okay. Go ahead.
Sir, initial Holter, which was done outside, showed a BPC burden of 48%, although patient didn't have any palpitations, sir. Post this, there were monomorphic BPCs. Post this, patient was, and NSVT runs were also there. He was started outside with metoprolol succinate 50 mg, and when he came to us, we did another Holter, which showed only 4% BPC burden, and his heart rate probably is low because of metoprolol succinate, sir.
Okay.
Sir, we went ahead with further investigations. Pro BNP was 12,200. Prop T was not elevated, sir, negative. CRP was 35. And if we were suspecting any dye poisoning, like some compounds I have mentioned, then in those cases, all the case reports, CPK levels were in 50,000, 60,000. But this patient's CPK levels were normal. ESR was 2, and thyroid was normal. Sorry, patient was euthyroid, and viral markers were negative. Patient had a persistent dyselectrolytemia, potassium around 2.9, that we are regularly managing with IV correction and oral corrections. Creatinine was 1.37, suggestive of a AKI component, and since he was having these bone abnormalities, so we checked his calcium and phosphorus and ionized calcium. They were low normal, almost in the normal range. Serum protein levels were normal. His total bilirubin was 3.4 and direct fraction was 1.5. AST, ALT were elevated. Hemoglobin was 16 with a TLC of 9800. All his scrub, leptospira, brucella, typhoid, all were negative. We did for any viral myocarditis, varicella, then toxoplasma, VDRL, blood culture, IE protocol were negative. Urine cultures were sterile. Vitamin D levels were very low, and intact parathormone was elevated. In the background of normal or low to normal serum calcium, we suspected that either it is because of secondary hyperparathyroidism, or there is some pseudo hyperparathyroidism in which these metacarpal abnormalities are
detected.
known. So we got an endocrinology consultation. They have asked that they are most probably of opinion for this that it is a secondary hyperparathyroidism. Although we have sent for this patient a whole exome sequencing, which will include gene as mutation, which will identify pseudo hyperparathyroidism. And his age was 22, so and the MRI pattern was the first DD for the LGE pattern in MRI is either it is a genetic DCM or a post myocarditis sequelae or a toxin. Even the toxin related cardiomyopathy also causes the similar subepicardial enhancement, sir. His ACE levels, since he was a young.
No, 1 second. This MRI, they use a criteria, called Lake-Lewis criteria.
You have investigated him very well. I agree with you. Because what I've just noticed is the tropa is normal, while the myocardial side damage is very less. But obviously, the myocardial stress is much more. That is the BNP. So I don't feel there is any active inflammation with myocardial necrosis. It's more a dilated cardiomyopathy picture now.
ACE levels are normal. AC levels are normal. Okay.
His genetic study is awaited, sir. Currently, our provisional diagnosis for him is severe biventricular dysfunction, likely non-ischemic, with moderate to severe MR, sir, moderate TR, and mild pulmonary hypertension. He's in heart failure with sinus rhythm and NYHA class 4 with mild pericardial effusion and no signs of infective endocarditis, with query secondary hyperparathyroidism bar pseudo hyperparathyroidism. and possible etiologies are post-viral myocarditis cyclase, genetic DCM or toxin-induced DCM or idiopathic DCM.
I think it's quite good. I think, Bala, what do you think? It's well
Yeah,
investigated. I think we have gone through all the angles, including the genetic
I
studies,
still
which I
feel
think
it could
the
be
results are
because
awaited.
this
Of course, there's no
COVID has
family
given
history. So generally, the family history is important because these are all autosomal dominant inheritance.
dominant.
So certainly, unless he is the index mutation, generally a family history should be there.
Yes, sir.
Anyway, it could be any of the other ones, including alcohol. I don't think he's taken enough alcohol. It's just 2
To
packs a
cause.
day. I averaging it will be 2 packs per day. That should not be a cause for alcohol related, unless it is he's addicted to some drugs like cocaine, which can cause acute myocarditis. Yeah.
So actually, this COVID has given a new set of diseases which occurs in younger individuals, no? Post-COVID, either vaccination or without vaccination, long term, they have post-viral myocarditis, and many of them have started presenting with DCM. That's what I feel.
Yes,
So
sir.
we must consider if he has been treated for COVID earlier.
Dr. Pramod, this ring-like enhancement in MRI is more or less suggestive of
Yes, sir.
genetic cardiomyopathy, isn't it?
Yes, sir. Yes, sir.
Yes.
Because FLNC and all are notorious to produce this ring-like enhancement. That's
Yes.
what I have read from somewhere.
Sir, we are also keeping it for probably for RBM20 also, because his age is very young and he had so many BPCs. So RBM20 is also a possibility.
Yeah. Good.
Probably by next week we will get the genetic report, sir.
Okay.
Okay. Anyway, he's already on all the 4 disease modifying drugs: metoprolol, spironolactone, DAPA, and sacubitril/valsartan. Obviously, decongestant torsemide. I'm surprised that he tolerates metoprolol 50 mg, but I think he's doing well. His heart rate has settled down a little. The ventricular ectopics have become less. Maybe he's tolerating it well. Okay, I think it's a good case and good presentation and well worked up, I think.
Thank you, sir.
Bala, shall we?
Yeah, it's a very nicely presented. It is still.
We'll hand over to Dr. Rajesh.
Myocarditis, although genetic component has to be investigated. Okay.
Thank you. Thanks to the examiners, Dr. Mahendran and Tarayan sir. And we'll move on to the last part of the today's academic session. It is OSCE by Dr. Rajesh. So I think Pramod, your team is with you to answer. Sir? Your team is with you to take the quiz questions.
Yes, sir. Yes, sir.
Yeah. I think Rajesh, our students will be because your students may have seen your questions. So we thought our students will be the ones to answer.
They might not have seen this.
Okay. Okay. Seeing your Twitter, I think it is too difficult.
Can you see that?
Yeah, we can see. Over to Rajesh.
Yeah.
Okay. So anyway, this is a heart failure session. So we'll start with a question on heart failure. What is the cause for elevated JVP in this patient? Simple one. Very simple. Straightforward. Quick. Anyone?
Come on. With ruptured sinus of Valsalva to RV, sir.
Just see the interventricular septum. Just see the interventricular septum. What is it doing? Just see the shape of the left ventricle. It's something appear like bullet shaped in parasternal long axis. What is that septum doing? What is that movement called? Described. It is diagnostic of a condition.
Shudder.
Yeah, this is septal shudder of consecutive pericarditis. Okay, so never miss it. See the pericardium, as Tarayan sir told, it appears obviously thickened with some cheesy material between the 2 layers of pericardium. Okay, so never miss consecutive pericarditis. And in all cases of the so-called cirrhosis liver, always look at the JVP of the patient. Okay, whenever you get a consultation and pick up cases. Okay, I think SCT must tell the answer. A case of right heart failure, what is the diagnosis?
Teams.
Okay, one is not moving. Okay. What is it? See, the right ventricle is very small, isn't it? And severe
RVEMF.
tear. Yeah?
RVEMF. Sir.
Yeah, correct. Okay, REMF. Now, this question, you just see this one. Again, you have to answer this. RVOT Doppler in a case of EMF and distended JVB. What is this physiology called? Publication is from your institute only.
Acquired.
Yeah, very good. Acquired Fontan physiology in EMF. I will rush through so that we can stop at 8:30 itself. So this is a patient who came with heart failure. What is the cath finding? It's a typical finding. Just look at LV and RV pressures and then see.
Interventricular dependence.
Discordant.
Interventricular dependence is there, sir.
Excellent, excellent. You can see when the left ventricular pressure falls, the RV pressure rises. So
RV pressures rises.
yeah. So this is interventricular dependence. Very good. So it's a patient with heart failure, and this is a transesophageal echo, and color MO through the mitral regurgitation jet. What is your comment?
Sir, diastolic MR, sir.
Biphasic MR, sir.
Yeah.
Yeah, very good.
Diastolic and systolic.
No, not biphasic. It's actually, sorry, not diastolic and systolic MR. This is actually called biphasic MR. You just see the initial systole and the end systole. So in between the middle part, there is nothing. Okay. So this is very important because when you measure the single frame measurements like vena contracta, bit, pisa radius, and the MR area, this should be kept in mind. So you can overestimate or underestimate the mitral regurgitation, and they must be very careful when you are using maybe one or two single frame measurements like vena contracta width or the pisa radius, just to assess the MR severity. Okay. Simple one. Very simple one. Patients with chronic heart failure. What is the finding? What is the diagnosis?
Rarely seen now.
Chronic MS with pulmonary hemosiderosis.
Very good, very good, very good. Okay, so this is the typical pulmonary hemosiderosis, maybe historical X-ray. You've seen only one case, and somehow we took it. So you can see the main pulmonary artery dilated, probably the LA appendage region. Then anyway, it's not a very good X-ray, but the hemosiderosis is the correct answer. Okay. This was referred from our ENT department for pre-operative evaluation of cochlear implant. Actually, the kids' CVS was normal. So in the busy OP where we handle some 600 patients, I just casually asked the bystander whether there is any other issues, and they passively mentioned that child has resistant seizures. So the child is on treatment by neurologists. And then I elicited a family history, and then they told that there's strong family history of so-called resistant seizures, and a few kids have died during seizures. So what's the diagnosis?
Long QT with hearing abnormalities, sir.
What is the correct diagnosis? It's coming from ENT for deafness, cochlear implant. So what is a syndrome?
Classical.
What is it?
There is a syndrome.
What is the syndrome?
Long QT with hearing abnormalities, sir. Jervell-Lang-Nielsen syndrome.
Correct. Jervell-Lang. So the take-home message is all resistant seizures, whether in children or adults, at least one ECG must be taken. You probably best is to immediately after a seizure episode, you take the ECG, and you can see what is the most striking finding? So this was taken after a seizure.
Long QT, sir.
Yeah, long QT is there, but one. Why? What?
With the T-wave heterogeneity is there, sir.
T-wave?
Alternates.
T-wave
Yeah,
heterogeneity
correct.
is there, sir.
T-wave alternate. See, it's a typical T-wave alternate. So you see this T-wave, then this one. So it's a typical T-wave alternance, which you can get immediately after a cardiac arrest. Okay. So what is the cause for mitral regurgitation?
Single papillary message, sir.
Okay, look carefully. During the case discussion, you have accidentally mentioned that term. How is the ventricle? It is not enlarged, isn't it? It is contracting normally, isn't it? So there is an MR. Atria are dilated. Both atria are dilated.
Yes, sir. ATL functional MR, AFMR.
Okay. So what is that? What is that mitral valve abnormality called? You don't see the posterior leaflet, isn't it? So what is it? Atrial functional MR can be a full question for you. Okay. So what is this called? This is called hamstringing of muscles. Okay. Hamstring posterior leaflet. You can go and read. There's an article in American Society of Echo about hamstring leaflet. So this is the one which I have been referring to. You can go and read. So this patient had a major non-cardiac surgery. The very next day after this TE, what was the surgery done, or what is the probable diagnosis? I told you non-cardiac surgery. So what do you find? It's a huge intracardiac mass, isn't it? So coming through the IVC. So what is the most
RCC,
common?
sir, renal cell carcinoma.
Yeah, okay, correct. Renal cell carcinoma. So he underwent a combined CVS.
Nephrectomy.
Yeah, okay. CVTS.
He underwent nephrectomy for RCC.
Yeah. Okay. So what is the cause for right heart failure of this patient? Patient has been on treatment for bronchial asthma.
Carcinoid.
Pardon?
Carcinoid.
Yeah, carcinoid syndrome. Because you can see the thick and diverted, immobile, typical tricuspid leaflets. Okay. And the left heart not involved. Okay. Just for the variety, I am showing
Balloon
this.
assisted ASD device closure, sir.
Okay. Balloon assisted ASD device closure. Okay. Simple one.
What is the lead?
Are we lead in situ?
Yeah. Where is the lead coming from?
From the left SVC.
CS.
Left
Yeah.
SVC
CS to
coronary
Correct. CS is dilated, so it is left SVC to CS to RV. So there's a beautiful article in Indian Heart Journal about how to do the pacemaker in this scenario. You can go and read. Okay. So this patient had 5/6 long ejection systolic murmur along the left sternal border. What is the diagnosis? Okay.
Valvar
Heart is
PS,
not
sir.
enlarged. Pardon?
Valvar PS. Valvar PS.
Excellent. You can see the main pulmonary artery dilated and
Post stenotic dilatation is there.
yeah, and the LP are dilated. Okay.
LP
RP are not dilated, but main pulmonary artery and LP are dilated. So that is a diagnostic clue. Okay. So this patient was admitted and for brain abscess and was drained in neurosurgery. So what's the most probable diagnosis? So there was no
Within 3
murmur.
cycles, there is left to right.
Pardon?
Sorry.
See, literally no significant bubbles coming on the right side, isn't it? Only towards the end a little bit is coming. This is mainly filling the left heart. So the echo was reported from multiple hospitals as normal. Then no murmurs. So what do you think? There is a past history of brain abscess also. whenever you inject contrast, you always inject on the left upper limb, probably. Okay, to see what.
Yes, sir.
What systemic
LSVC
anomaly?
to
Yeah. Okay. So left SVC.
left SVC, sir.
Yeah, left SVC draining to. So in
Unroofed
all
unroofed
such
CS
cases,
also.
recurrent CNS infections and all. So never stop the echo with your usual 2D, 3D and all. Unless you do a contrast echo through the left upper limb, you will miss this deadly combination, deadly diagnosis. Okay. Again, simple, straightforward one. 32-year-old female with severe PH. What is the diagnosis? Look carefully. So see the mitral valve, then LA. There is a membrane inside the left atrium, isn't it? So what is it?
Port atrium sinister, sir.
Yeah.
Yes.
Okay. So I'll rush through it. So 8-year-old boy, pulsations in the second left intercostal space, loud second heart sound. Somebody confused it as PH, but it was not PH. So what is it? Post-operative. What is the finding? Tell one important finding. Okay, what is this? Bulge going up. L post aorta. Okay.
L post.
So never
Post ASO, sir. Post ASO for TG.
Pardon?
No.
No. That was L post aorta.
Corrected
Okay.
transposition or whatever.
Okay. So this is a hypertensive patient on enalapril 5 milligram twice daily.
Hyperkalemia, sir. Hyperkalemia.
Very, very good. Okay. So many thought it has that hyperacute T wave of myocardial infarction, but so you may get the potassium values and all after 1 hour or 2 hours, but always treat for it. Okay. So patient with right heart failure, what are the findings and probable diagnosis? Simple one. See the RV apex.
Obliteration of RV apex with.
Yeah, obliteration of the RV apex. There's a huge RA clot. RA is hugely dilated compared to LA. So what is it? EMF. Okay. So, but the question is, where exactly is the thrombus attached to?
It is extending from IVC into RA, sir.
Not IVC. You look carefully in the bicaval view. In mitral stenosis, also the same structure may be a source for pulmonary embolism clots. It's from RA appendage. Okay, so see, this region is the RA appendage, and this is a.
But RA appendage usually don't have any thrombus, sir, because of continuous SVC drainage into RA appendage.
You can have. So, what is the likely severity of MR in this patient? Mild or significant?
Severe
what
MR.
Is the finding called?
Severe MR, it is due to color Doppler splay, sir.
Yeah, correct. So this is what is called the color Doppler splay, and this is how you see it. So you can even measure the splay width, and there are some studies saying that more than 17 mm of splay width is suggestive of severe MR. Okay. So ACT, I think, should tell this last one. So with that, we will stop. 8:30 sharp. 15-year-old boy with history of cardiac surgery twice. Now presents with heart failure. Comments.
Single ventricle with tricuspid atresia, Fontane's.
Yeah, very good. So you can see the extracardiac Fontan here.
Maybe AVVR is leading to AVVR and single ventricle dysfunction is leading to heart failure, sir.
Yeah. Okay. Good. Okay. Anyway, there is 1 minute more. So 26-year-old female who had a renal biopsy 1 year back now presents with effort dyspnea. Possibilities. See the next slide also. You can see, you look at the valve, mitral valve, carefully. You see the ventricles, the myocardium. Okay. And I'm going to the next slide. Okay. So what is the most probable diagnosis?
Cardiac amyloidosis.
Not amyloidosis. 26-year-old female who had a renal biopsy. See the myocardium? It is
SLE, sir.
dysfunctional,
SLE.
isn't it?
SLE.
Yeah, correct. So there is pericardial effusion. Then there is mitral valve is thickened with no commissural fusion. No commissural fusion. So severe mitral vegetation. So in young females with this thing. Okay, last one. We will stop here. So what is this Doppler from the LA appendage suggestive of?
LA velocity, appendage velocity.
Yeah,
More
what is the
than point,
diagnosis?
more than point.
Is it normal or abnormal?
Abnormal. Velocity is 0.4, sir.
Okay.
So LA appendage clot is there. So we
This
should
is not the
proceed
way
further.
the normal LA appendage velocity look like. You see lots of waves. So what's it? ECG also will give you a clue, you know. Okay, this is how the LA appendage velocity of atrial flutter looks like. Okay. Okay, thank you. It's 8:30. I think we will finish here. Okay.
Yeah, great, Rajesh. Great.
Thank you,
Good.
sir.
I think
Okay.
this has been a wonderful session, starting with Prabhakar. The case was worked up very beautifully, and I think the answers were, most of them were spot on. And I think spotters, amazing. But the best part was a lot of people in the audience were giving correct answers. So I think shows involvement of people. So great. I think it was a wonderful start to the new season. And let's keep going. Abraham, Hari? Okay, I think maybe Hari is busy. So with that, I would like to thank everybody for a wonderful session and see you next month for another wonderful session. See you. Good night.
Thank you, sir. Good night.
Right.